quite a number of cases, so I'm pretty sure that we will, in the 60 minutes, hear a lot of new things and see a lot of, I hope, interesting cases so that we can end up to be at time at the lunch. So some research grants to disclosure, and here is the purpose or the outlook of my talk. I will speak about tips and tricks how to perform MR-guided biopsies, MR-guided hook wire markings. I will speak about complications, which needles you should use, and of course also on the results of different trials to see how good or excellent almost MR-guided interventions are. I'm pretty sure that all of you have heard and are, pretty aware that MRI of the breast with contrast is now available almost 30 years. In this long period, we learned that I would say specialists in radiology, those who have knowledge about mammography and ultrasound, and of course biopsy, should also report MRI of the breast. You should read at least 150 breasts MRI per year. It's not even one per day. But whenever you offer to introduce contrast-enhanced MRI of the breast, then I would strongly recommend that you also have to, maybe not your institution alone, but in a sort of cooperation, offer MR-guided interventions. This is a necessity, as you just saw on some of the cases. So in these 30 years, we are working on our indications, so that there are a lot of indications, and based on these indications, even if we only work according to these indications, we will see a lot of cases. And the numbers of MRI of the breast is increasing. When we speak about market potential, MRI of the breast and MRI of the prostate are the rising stars among the next years. So these are two very important topics. Here you see the results of a survey. I presented this already to you in the morning, and there you see the reflection of the radiologists, how they use and how they behave in accordance to these indications. And there you see that, as said, a lot of these indications are indeed used. Let's say MRI in the assessment of implants, MRI in a high-risk screening population, MRI in case of nipple discharge or neoadjuvant chemotherapy, or even in cancer of unknown potential or primary. It's very often used. Even in case of the problem, even in problem-solving cases, very important, and even as a preoperative staging tool, particularly invasive lobular cancer. There are, of course, some difference between different countries, but overall, it is very well accepted. Also very important when you do MRI of the breast, you have to use structured systems, structured reporting system. I just went to the other room there. I just saw that the BIRATS lexicon is already translated to Spanish, so I can strongly recommend to use this. And based on this BIRATS lexicon and on a lot of cases you will see every day, you will come up with a, let's say, decent diagnosis. What I strongly recommend as an add-on to BIRATS is our so-called classification system. This is a very robust one. It is published by Pascal Balzer, who works now in Vienna, and a lot of other papers based on these first papers have been published, telling that the radiologists really like to use this classification system in add on to the BI-RADS system, because this gives you a structured classification algorithm where you have to place your lesions. Very simple, but very robust. So whenever you use BI-RADS and such classification system, you will end up with a BI-RADS number, and we all know that in BI-RADS 4 and 5 we need a biopsy. This is a very old slide, but it is a very trustful slide, and it tells you also something about the history. When I used this slide in, let's say, 2002, and I stated that in 90% of all BI-RADS 4 and 5 lesions, needle biopsy should be performed prior to open breast biopsy, there was always a huge cry, oops, so like that, a huge noise in the auditorium, because everyone said, that's not possible. We will not do so many biopsies. In the meantime, biopsy is a procedure which we offer almost every day to all patients. And of course, we are also supported about the concept of neoadjuvant chemotherapy. There's a lot of people want to know the histology, want to get a tissue which then can be assessed genetically and used for further therapy decisions. So in the meantime, we have a lot of biopsies, a lot of work to do. But when we have a closer look to the results, and you will see it later as well, we have to see also the numbers. If we perform 100 breast biopsies, even the best institution, only 20 to 30 cancers are found. 70% are benign. So this is always a dilemma. And we have to improve this number, that we are getting more specific, particularly if we're starting to use MRI of the breast as a screening tool. Pretty sure you heard that with these abbreviation protocols, we see more cancers, but we produce also more false positives and more biopsies. So I still like the concept of abbreviation protocols, but I do think that we have to add at least a more specific tool like diffusion-weighted imaging, where we can nicely demonstrate by adding contrast to diffusion that we can reduce unnecessary breast biopsies. And I'm so happy that I'm not aware, that you know, that I'm not sure if you're aware that Julia is running this diffusion-weighted imaging group among USOBI, and what I learned is that this is indeed, a very productive group, and I hope that we can also, together with the companies, starting to produce a robust technique that everyone can use. Diffusion-weighted imaging, very simple. So, but let's now start with respect how to perform a biopsy or an MR-guided intervention. So let's start. We do a mammogram, and based on this mammogram, we want to perform an MRI. And here is already the first important information. Buy the best coil you can get. Coils are the most important part with respect to Tesla, but they should have a lot of channels, 16, 18, even 36 channels, and they should allow fixation of the breast, not compression, but also very important, these fixation plates can be removed and replaced by a fixation plate that can be used then for biopsies. You will see it later. So whenever you buy a coil where you can do both contrast-enhanced MRI and interventions. So let's start now with this case. We did an MRI, as said before, of this breast. You see that this patient had already more or less implant surgery because of a reconstruction process, and now in this so-called MRI we saw a non-mass enhancing area. And what is the next step? So the next step is, when you see this on MRI, that you perform a second look ultrasound. And the reason why we want to perform a second look ultrasound is clear and simple. If you see the lesion, which you have seen first only on MRI, you can then go back and do ultrasound-guided biopsy. So there is a very nice article published the last years where Claudio Spick and Pascal Balzer, both are from Vienna, did a meta-analysis, included 17 studies, and demonstrated that the detection rate of lesions which are seen primarily on MRI are in retrospect seen in 20 to 80% with second look ultrasound. And the detection rate of masses is higher than in non-mass enhancing areas, and the detection rate is higher in cancers than in benign lesion. But still, if you do not see the lesion on second look ultrasound, it does not mean that you do not have to perform a biopsy. You still have then to go back and do an EMA-guided biopsy. So, as said, about 40, in the best, 40% of the lesion can be seen in second look ultrasound, more masses than non-mass enhancing areas, and it is of course clear that such tiny lesions as here are hardly to depict, and in this case you will go and do an MRI-guided biopsy. But when you see them, do an ultrasound-guided biopsy, fast, simple, cost-efficient, and very safe. So, you now excluded already some of the patient. You are ending up now to do EMA-guided biopsy or EMA-guided hook wire. What is your first thing what you will do? You will start to inform the patient about the procedure. This is now mandatory. The best is to sign a sort of contract, and we have different languages around when we use it in Europe, but nevertheless, I want to more or less go through this with you because I do think that it is always necessary to be prepared for specific questions. So almost every woman is asking about pain. Is it painful? What can you answer? First of all, we will do it in an outpatient setting. You will not stay in the hospital. We will inject a local anesthesia. When we inject the local anesthesia, the pain should be very minimal. Whenever after the biopsy you have pain, take pills, take a pain reliever, or put on cool bags on the breast so that it's not so swollen and so painful. Collapse is very rare, and what you also have to explain that she will always ever have a bruise. Sometimes a tiny one, sometimes a little bigger one, but overall we cannot avoid a bruise, but from the amount of hematoma or bruises, this is after surgery, this is after biopsy, you see that there is a dramatic difference. Of course, we will not always do this bandage, only if it is necessary, but we have to do we will put on a bandage, of course. Infections and really strong complications are very rare, and I was really lucky to find this publication because it more or less tells you about the numbers of severe complications when any breast intervention is performed with different systems. And what we can learn is that almost from these 200 cases, almost 200 cases, 80% had no complication, 0 complication, and the remaining 20% had grade 1 complication, which means that like hemorrhage, or if you use, for example, systems where you heat up the tissue, some skin burns, and delayed wound healing. So it can be considered a very safe and accurate technique, and as you see, infections are very rare. However, it can happen, and I always searched for such a case because I couldn't believe that it happens when you do a breast biopsy. But it happened in our department, luckily not performed by a breast intervention. It was performed by an interventional radiologist who was asked to perform a biopsy of this area, of this area. And do you know what happened? If you are experienced and see the needle tip before he fires the needle, could you imagine what happened? This is the lesion, this is the needle tip, and when you have here the ruler, you see that the lesion usually, or that the needle usually advances more than 2 centimeters. So this was more than 2 centimeters, and what you see here was the pleura. So, and it happened, this pneumothorax, luckily the interventional guy solved this issue by themselves by putting in a pneumovac during CT guidance, and so nothing severe happened, but it happens sometimes. A very important question, which will come, I would say, in 70% of all patients, is it really good to perform a biopsy? Because of tumor seeding, is it not better to go directly to the surgeon? So what we have to tell them is seeding of cells can't be excluded, because we all know that there are, let's say, dead cell particles always constantly from tumor cells are floating through the body. We have to inform them, of course, but we also have to say that there are a lot of evidence that the recurrence cancer rate is not increasing in this group of patients. We by ourselves did a study where we compared the recurrence rate of cancers in 2 groups. One who had surgery alone, and others who had surgery after biopsy. And it turned out that it was almost the same. So there is no effect on tumor seeding. We now inform the patient, and in the next step, we have to take some considerations regarding biopsy device, about the coil, and so on. So, first, this is such a coil, and there you see that this coil has an opening. This is a breast coil, and in this opening, you can place more or less this stereotactic plastic device, and this stereotactic plastic device carries 2 plates. And these 2 plates are important. With these 2 plates, you can stabilize the breast. And then, I will explain it later, you have 2 options to perform a marking of the lesion, either by the grid technique or by the post and pillow technique. I will come later to this. Why do we need these compression plates? We have to compress the breast a little bit so that it is not moving away from the needle. Here a closer look now to these compression plates, and let's first start with the grid. This is like a grid system, and this is a so-called more or less cuboid, and this cuboid carries a fiducial. A fiducial is a sort of pan which carries a mixture of gadolinium and water, which can then be seen on the MRI scan. With the post and pillow technique, it's a little bit different. There is this column, and these columns you can move on the x-axis, and there is an additional square on this column, and this can be moved in the y-axis. So you can go in all directions, and therefore it is very safe and accurate. Regarding technique, you use the same imaging protocol you use with the same amount of contrast agent you use for the diagnostic scan. Very simple. So when you purchase an MRI coil, currently, almost all come with a software package. And this software package makes it very easy for you. It is like, click here, and they say what you have to do, where you have to go. You can choose different needles, and they will automatically, you will see it later, explain how deep you have to penetrate the lesion, the needle, etc. So, again, here you see two sorts of compression plates, post and pillow, and the grid system, always carrying this fiducial. As said, this fiducial is like a pen having a sort of solution inside, and here it is. This is the contrast-enhanced MRI. After subtraction, you see a lesion. On the T1 weighted scan, before and after contrast media application, before any subtraction, you do see this fiducial. This is a bright signal like a pen. So, and I will now in the next couple of minutes do one case with you together, and we do, let's say, not a case without the supportance of the software. We do it when we have a crash, you know, when the system collapses, so that whenever you want to do it without this system, you can do it, because it is very simple. And this was when we started years ago to perform such an MR-guided intervention. When you do such an MRI scan, you find always numbers on these images. One number is very important, that this is the table position, okay? So when you know the table position of the lesion and you know the table position of the fiducial, you only have to bring the fiducial to the table position of the lesion. And this is done now. So it's only, you have to go in either the direction of the head or in the direction of the feet. If you have done this, as for example in this case, as said, you only have to, let's go back, to more or less assess and determine the depth of the lesion. That means how many millimeters or centimeters do I have to penetrate the needle from the skin to the lesion. So in this case, you have a ruler here, you say it's about 2.5 centimeters. So you then know I have to push this, you know, needle 2.5 centimeters into the breast, and then I can do the biopsy. With the software system, everything is calculated automatically, and there you see it says exactly where you have to move the needle, so nothing can happen. Here is a case which I want to show you. We start now, we have calculated the numbers, and we start with a local anesthesia, we wait, do a skin incision, and then we place the trocar. So these trocars, this is a steel trocar, it can be more or less pushed through the skin to the lesion. It will then be replaced by this plastic trocar. And again, this plastic trocar can be easily seen and guides more or less, or is more or less the tunnel for the biopsy system. So we remove then the trocar, enter with the biopsy gun, take out tissue, and finally we place a clip. Here is this case which I showed you first. We all know that the lesion was here. So in the first run, we learn now that the fiducial is more or less not in a proper place. So when we would perform the biopsy, we would end up here. But in reality, the tip should point to this area. So what you have to do is you have to angulate this tiny little pen in this direction. So we did this. Here is the old position, and there you see this gray line indicates the new position. So when you see this, you can be sure that you can hit this area. So here you see it better. Here is this area. And what we did then is the biopsy. Biopsy is not done in the magnet, it's done out of the magnet. And there you see already the clip swimming in the hematoseroma of the biopsy cavity. Why did I explain this? This clip placement is very important, either for preoperative neoadjuvant chemotherapy, or when you want to perform a surgery after your biopsy. Very often these hematomas can still be seen even after weeks. So you see them as a hematoseroma with the clip, and so it can easily be, ultrasound can easily be used to perform such a hook wire marking and before any prior surgery. Or you can of course also more or less do a stereotactic marking with a hook wire and so on. Some words regarding hook wire marking. It will still happen that not all lesions can be biopsied, maybe because of a technical failure or because the woman insists that she wants to have surgery without any biopsy. So then you have to perform a hook wire marking with MRI. This is more or less the identical protocol as you would use for the biopsy. You more or less then place a hook wire with the same procedure as I explained, and you can easily mark this area. Always important is, even as a radiologist, to compare the imaging findings and the final histology. Here you see such a needle carrying this hook, and then finally the placement of the hook very close to the lesion, and this is can be considered a very successful technique. Its success rate close to 100%. These are the results of different groups among the world. So, but after this small, tiny little chapter with respect to MR-guided hook wire marking, I want to come back to MR-guided biopsies, which needles should be used. There is a common agreement that if you perform MR-guided biopsy, you should use vacuum systems, okay, instead of these spring-loaded guns. Why? Because you can more or less produce and deliver more tissue, and particularly if you perform this high-end technique like MRI, you always want to be on the safe side with your diagnosis. The good thing is that old systems are still available, but they no longer be sold, and therefore the collection of the tissue is no longer done by this opening. All the new systems offer in the meantime a so-called basket system where all the specimens are collected during such a procedure in a basket, and this is very convenient, particularly for the technologists and for the doctors, as we see less contamination with blood, etc. What can we say regarding the results of MR-guided vacuum biopsy? There is a very old study, but it was one of the first, therefore I always want to show it. It was published already in 2001, multi-center study, including 5 centers among the EU. They did more than 500 procedures, report a success rate at that time already from 96%. No cancer were missed. Some years later, a publication came from the States telling the same, that MR-guided vacuum-assisted breast biopsy is indeed a trustful and very important instrument. This shows more or less a nice overview what results have been achieved over the last 15 years. Here you see all these references which lead more or less to these results. What we can say is that it is about technically not possible in around 7%. The false negative rate is very low, 1%, 2%, 3%. We still find high-risk lesions in about 20%. This leads to an underestimation rate of about 13 to 50%, depending which lesions you are included. And we see no severe complications. Very important and very trustful technique. Here are the results of our own study group from Vienna. So we included 500 lesions which have been performed between 2006 and 2013. Here you see the numbers with respect to malignant, high risk, and benign. And as mentioned, in average, and I consider us as an expert center, we produce too many false positives. We have a close to 70%, about 20% cancers, and the remaining are high-risk lesions. These both need surgery, okay? When we compared 3 different systems, all of them were vacuum systems, we did not see really a big difference among the system, which is also good to know. It's like driving a car. Sometimes it's a little bit faster and it's better looking, but overall, all cars bring us to the same endpoint. High-risk lesions need biopsy, and very important, we cannot predict, unfortunately, with any imaging, particularly with MRI, the underestimation rate or high-risk lesions. So whenever the result came out, we have to act and have to perform an open biopsy. In case of discrepancy between imaging and histology, rebiopsy is necessary. So, thanks a lot. I have one. Thanks. Rebiopsy is necessary. Let's do in a case, if you have this lesion and you do a biopsy and histology tells you that this is a cancer, are you happy? Yeah. Yes, a cancer is good in this case. If this lesion undergoes biopsy and it turns out on histology that you produced only fatty tissue, then it's something wrong. There is a discordance and you have to do the biopsy again. Overall, what can we conclude? We need good equipment. We need MR-guided coils. The lesion size depends between tiny little lesion and big ones. Whenever you have the chance to do a second look ultrasound to rule out and to exclude lesions. The discrepancy between histology and imaging is important to consider, and when there is a mismatch, you have to perform the biopsy again. There is, of course, a learning curve. You need, I would say, 10 MR-guided interventions, and then you are on the safe side. In the last 2 minutes, I want to give you an outlook, what's going on in the meantime with MR as a therapeutic tool. You will, of course, consider MR-guided biopsy as a diagnostic tool and not a therapeutic one, but there are some available. It's MR-guided focused ultrasound. All these techniques apply either a strong heat or a strong cooling effect that the cancer or that the cells die. This is MR-guided focused ultrasound. I know these are some old slides, but it's still available. It works very well. There is a Japanese group who does this since years, very successfully. They ablate the lesions by MR-guided focused ultrasound. Here you see how it works. There is the breast. You see a lesion. These are the targets, and you know these targets. Each of these points will be more or less treated with focused ultrasound, and overall, then the whole area will change and will lead to a necrosis of the tissue. Here you see some results in the follow-up of this patient. And there are some studies reporting that MR-guided focused ultrasound can be considered safe and as an alternative already to open biopsy. Same can be done, of course, under open magnets, similar to ultrasound, where you have your optical eye and the fiducial, and the optical eye and the fiducial are more or less connected, and under real time, you can easily move the needle, bring it to the lesion, and can do a biopsy or even an ablation procedure. Here they did it successfully with cryotherapy, and at that time they could already perform as you see here, some cases and could treat. This was already back in 2005, successfully several cancers by applying cooling up to minus 150 degrees, which causes cellular death and vascular obliteration. Here is an image how it looks like after such, or during the procedure and after such a procedure when you see the biopsy specimen. There you see the effect on the lesion. Very successful, and I'm pretty sure that EMA-guided intervention can indeed help to beat breast cancer. So, many thanks for your attention, and we are ending up now with my talk, and we'll start with the cases. Okay? So, first case, Julia, it's about 20 minutes.
Yeah, more or less. Yeah, because there is a honorary lecture at 12:30. So.
Okay. So let's start with the first case. No family history, no risk factors, and she has a palpable node in the right breast. Does everyone see the palpable node in the right breast? Yes? I help you here. I lined it. Great. Here again. So, what's that? Which technique? Tomo. I only want to show you that with Tomo it's much easier to depict this lesion because we get rid of superpositioning. There we have this area on the MLO, this is on the CC. In addition, we also see calcifications. Okay? Again here, comparison between mammography and Tomo. So even with mammography, we see a lot of tiny little calcification. And here is the MRI. What you see here is T1 before contrast, T1 after contrast. These are the subtraction images at 1 minute, 3 minutes, and 5 minutes. This is a T2 one. This is the diffusion weighted image, and this is the permeability map. Okay? So, how would you consider this lesion? If you see it on MRI, is it a Pirates 1, 2, 3, 4, or 5? 4. Very good. Correct answer. It's 4. What would you expect from histology when it comes back? Is it a cancer, fibroadenoma, fat necrosis? Hopefully, in this case, a cancer. Okay? Because it shows all the typical signs of a cancer. So it was an invasive ductal cancer grade 3, and if we more or less go back, we see here that the lesion enhances. You see a rim enhancement, a very strong one. The lesion is more or less indistinct, and this indicates that it is a lesion which should undergo biopsy, and it turned out to be an invasive ductal cancer. Very good. So, patient, no family history, risk factors, no. She has a palpable, painful nodule in the right breast. Where is the lesion? Right breast, do you see it? Hardly, or? So, do you see it here? Maybe here? What would you do next? We did an ultrasound, okay? And an ultrasound, it turned out that this looks like a cyst, okay? What would you do next? What would be the next step in your private practice? Do a biopsy. Okay, let's do a biopsy. She has pain. Okay, we do a biopsy. We do a fine needle biopsy, take out the liquid, and send it in to cytology. But afterwards, we will send her home. Of course. So, but we did a tomo. Do you see?
Yeah.
This area? And here, the ball. This was more or less the cyst, and this was the suspicious area, which causes pain. If we are going back now, even in retrospect, we have no chance to detect this cancer. So, and this is a case which can happen every day. Patient comes, you do an ultrasound, you see something, you are happy with the patient, it's only a cyst, but behind the cyst, we found this area. So this is the corresponding MRI. So again, T1 after contrast, T2, the dynamic scans in subtraction technique, and the permeability map. So next question, this is a step up or down. You see that the area is much bigger as we thought. Which pirates? 5, very good. What would you expect from diagnosis? Cancer, fibroadenoma, fat necrosis, abscess. I hope that everyone agrees that this is typical for an invasive ductal cancer, grade 3, and it should only demonstrate this case how powerful tomosynthesis is. So, yeah, next case. Bloody discharge from the left nipple, okay? Where is, do you see something on mammogram? Where is the cancer, left or right? Left, sure. Where? Maybe this is the cancer. Or here. There are some calcifications, so. Do you see something? She has nipple discharge left, okay? So we have to focus here. Maybe this is something.
Yeah.
Okay, I want to show you tomo. I'm pretty sure that you heard already that with tomo we detect 2 to 3 more cancers per 1,000, so we're ending up by 6 cancers per 1,000 instead of mammography 2 and 3. So, and these are the effects of tomo. There you nicely see easily the lesion, you detect it easier, and you can characterize it easier. Okay? This is mammo, this is tomo. So, contrast-enhanced MRI, there is the lesion, close by to the duct. That's the reason why she has this nipple discharge, okay? You see there is a little bit of ADC maps is going down. So the next question is, we see it, of course, if we search for it on ultrasound. On search, we see that it is highly vascularized. That's the reason why we see the contrast. So which pirates? I would say 5. It's okay, I can live with that. And the diagnosis was papilloma with ductal cancer inside. Okay? So who works already with tomo? You see? See? So it's about 30% overall in the world work already, 30 to 40%. No, overall. Yeah, so. Regarding papillomas, we have to take into account this publication, even if you have a benign papilloma on histology, some need to undergo surgery, as we see an upgrade in about 25% to cancer, particularly those who are seen in older women, and they are larger than 1 centimeter and are far away from the nipple. In this case, we rather recommend to perform biopsy. So, this is a new question type, So it's getting a little bit more complicated for you. But this is a new way how to ask questions. So what you see here is the history of a mammogram, MLO. She's 46 years. She was treated for cancer on the right breast 7 years ago, and she has a palpable lesion on the left side. Okay? There you see the mammogram, and there you see this area. Do you see it? So, and we want to know the most likely diagnosis. So, when it says most likely, only 1 or 2 are correct. Okay? Could this lesion be, as you see it here, an invasive breast cancer? No. No is false. Could this be a fibroadenoma? No. Could this be a liponecrosis? No. Could this be a hematoma? Yes, very good. Angiosarcoma? No, because angiosarcomas are rarely seen as a breast lesion. You see rather a skin change. Next. So, patient with left-sided mastodynia referred from an external institution. We have external mammograms, and we did an ultrasound and found a lot of cysts, okay? So, now, you see a lot of cysts, A, B, C, D. And there is a question, which of the cysts displayed on these images can be considered most suspicious for malignancy? A? No. A, I want to hear something. No, oops. So, it happens. So, A not, as a correct answer is C, very good. As you see some, solid areas within the cyst, and this, of course, is very suspicious, and we have to perform an ultrasound-guided biopsy. It is also considered to be a complex cyst. Okay? So, now, you see this again. Is this lesion a simple cyst? Yes or no? Is this a complicated cyst? Is this a complex cyst? Very good. Could this be a papillary breast cancer? Maybe is yes. There is no maybe. There is yes and no. Okay? And could this be a mucinous breast cancer? No?
Yes.
So, true and false. Okay? Correct answers. Great. So, next. 70-year-old woman underwent non-enhanced CT scan of the chest because she had dyspnea. Indicate the main finding not related to the clinical presentation which requires further workup. So what would you mark here? If someone asking you, what should you mark? Any answer?
The breast.
This is the CT, this is thorax, this is a fusion related to dyspnea. We don't want to mark this, but do you see here a difference? Yes. So this is something which has to be marked and needs further assessment. So there is a highly suspicious mass in the left breast, and therefore we need further assessment. So, oops, something happened. Of course, this looks like, something happened here. Okay. Can this be a breast cancer? Yes. Can this be a gynecomastia? No, because it's a woman. Can this be a reactive lymph node? Can this be a breast sarcoma? And can this be a breast abscess? No. Okay, a solid tumor, suspicious. We need to assess this, and therefore you have to recommend, even if you see a CT, further workup. Very good. So, next case. The patient had a palpable lump in the right breast. It's painful. She's 47 years. And we have imaging studies from January 2012 and June 2012. This is January 2012. Okay? Do you see something? Very dense. Okay. January 2012, very dense. June 2012, see something?
Yeah. Distortion.
Okay. We did an ultrasound. This corresponds to that. And we did an MRI. The very strong enhancing mass. Okay. Which pirates? 5? 4, it's okay, it's no problem. 4 or 5, it's important. Put it in the right category, we'll do a biopsy. So, what are you expecting?
I'm scared.
The whole thing developed within 6 months. What could it be? Radial scar? No. So, right answer is granulomatous mastitis. It's not a lymphoma. Lymphoma looks not like a star, it looks rather like a ball. It could, of course, be an invasive breast cancer, but this is rarely seen. I don't want to say that it cannot happen, but in such a short period, very rare. And in this case, it was a granulomatous mastitis. It always shows signs of inflammation. It happens to be in premenopausal woman. We need histology, and then it can be treated either with antibiotics or steroids. If you want to learn more about a mastitis, granulomatous mastitis, please read carefully this paper. It's very helpful. So, next case. We have a 52-year-old female, high-risk patient, presents for her mammogram and MRI. She had a history of TCSS in the right breast. It was benign, but she has also an unchanged lesion in the breast since years, and this is the corresponding MRI. Okay? So, on MRI, after contrast, and it looks like that. We mark it, and we say that this is a well-defined mass lesion in the right breast, which shows some contrast enhancement. What is your differential diagnosis? And take into consideration the imaging findings on mammography and the long, rather benign history. Is this a fat necrosis? Is this a hematoma? Yes. Is this a breast implant? No. Is it a breast abscess? No. Could be, of course, a lymphoma. Okay, very good. So now you know how hematomas could look like on MRI as well. What course of action would you do in such a scenario? Would you perform a biopsy? No. Would you perform surgery? No. Observation is always good, but in this case not necessary. We should not perform surgery since it is a benign lesion. Yes, and we do not need antibiotic therapy. Very good. So, next very interesting case, another type of question. The lesion in the left breast is, do not use more than 5 words to describe the lesion. So the best would be if you say fibroadenoma, cyst, cancer. Okay, maybe, and then you can use 5 words. You can add someone, is a prostate or breast? Breast. So it looks like, most likely, invasive breast cancer. So, and it is correct if you said breast cancer, invasive cancer. You can also say this, and very important, lymph node metastasis. So, very important sign. So, next question to this case. How is this possible that Jürgen Futterer is already here? You gave the same, no, kidding. So, given the present image and the diagnosis of adenocarcinoma, what is the clinical stage? It's about 2.8 centimeters in diameter. Is it T1N1? No. Is it T1? No. Oh, what? No. Is it T2N1? Yeah. Size and lymph node. Very good. No. And the other one is also no, because it is a positive lymph node. Yeah. Very good. So, Julia, one last case.
Okay.
One last case. Simple case. We hate these cases if you have to read them. T2-weighted image of the breast. We see a lot of cysts, okay? And I want to know, and I point the arrow to this area, okay? Not to this, to this. Do not use more than 5 words. What would you say? Complex cyst, yeah? Complex cyst, very good. Not complicated, complex. And this is correct. Could, of course, be an inflammation, but complex cyst is correct. What would you do next? Would you do fine needle aspiration? Yes or no? Or would you rather do a stronger needle, like vacuum-assisted biopsy, or surgical excision, or should we suggest neoadjuvant chemotherapy? Or should we suggest imaging follow-up? Also, fine needle, I would rather, in this case I would not do fine needle. It's better to do vacuum, or it is a complex cyst. Complex, you see that the wall was thickened, strong enhancing, and therefore I would do more tissue. No surgery, no suggestion for neoadjuvant chemotherapy, and we do not suggest imaging follow-up. We want to get a histology. Perfect. So I do think we stop here.
Yes, because
Okay.
we have the... Thank you very much for your
Thanks
talk,
a lot.
Professor Helbig. Les recuerdo que hay una